Hello, I'm Dr. Meg Thompson. I'm the third-year radiology resident at the University of Florida College of Veterinary Medicine, and I'm going to talk to you about radiology today. It's quite a big subject. We're going to touch a little bit upon equine and spend most of our time talking about small animal today. I'm a graduate of Tufts University. I did an internship at Angel Memorial, and I'm just about finished with my residency and starting to look for a job. So let's go on to the first slide, please. So just to review what we're going to talk about today, I'm going to talk to you a little bit in the beginning about study materials that are going to be available for you to use. Some of these you're going to need to purchase. Most likely the easiest place is on Amazon.com or some other internet-based organization such as that. I'm going to talk quickly about the physics. Obviously, it's not something that I can go over in depth, but just the things you may need to know for the board exam. I'm going to talk about the systematic approach to reading radiographs that you all need to employ in order to pass the NAVLE exam and also in everyday practice. And then I'm going to talk about differentials for a variety of appearances of radiographic abnormalities. And as I alluded to a little bit before, I'm going to talk to you about the musculoskeletal abnormalities, both large and small. And then in thorax and abdomen, we're primarily going to focus on the small animal patients, since that's where the majority of the exam is going to be centered. So as you know, diagnostics cover about 12% of what's on the exam. Of that, about 10% are going to include some images. There has been some ultrasound on the exam, and on the test examination that's actually on the internet on the site, there are some ultrasound questions. So as expected, most of the questions are going to come from our companion animals, from equine and canines and felines. That's going to compose the majority of where the questions are going to come, with a smaller percentage from pet birds, exotics, cows, and other food animals. The two textbooks that you need to think about purchasing or using in a library for radiology is Thrall, the textbook of diagnostic radiology. The third edition was out in 1998. There is not a huge amount of difference in the earlier editions if you actually have one of them and can use one of them. And then for the little bit of ultrasound that may be included, the text that is the most useful is Nyland and Mattoon, Veterinary Diagnostic Ultrasound. There is a new edition that just came out in 2002, but the reason I say list the first edition there is that it actually includes a fair bit of horses, which the second edition does not. So quick review of X-ray physics. As you all probably know, X-rays are produced in a cathode tube. A filament is heated, and the heated filament causes electrons to be distributed. Those electrons strike an anode at the other side of the tube. That anode produces X-rays, which are then projected towards the patient. The X-rays, once they've passed through the patient, cause the phosphors within the screens and the cassettes to emit light, and that light is actually what changes the silver halide in the film to the blacks and grays and whites that we're used to. So as you can see, black, grays, whites, they have areas that have been exposed or attenuated by the patient. And if you have a clear area, that area has had no light or radiation exposure. The degree of film blackening totally depends on the amount of energy that has passed through the patient, or how much energy has been attenuated by the patient once it reaches the film. And this is dependent on the tissue type, the density, how thick that tissue is, in terms of what we actually see on the radiographs. Again, this is a very quick overview, and there's a much better overview in the are all textbook for any of you that want to pursue this further. A quick mention on radiation safety, since this is one of the areas that veterinarians often have difficulty with. The basics of radiation safety are time, distance, and shielding. Time means you don't want to be in the room if you can be. So if you can use sedation, if you can use restraint, if you can rotate technicians, that's the best thing you can do. Distance, you'd like to be as far away from the X-ray tube as you possibly can in order to minimize your exposure. And then shielding means wearing lead aprons, lead goggles, and gloves. Just a quick note on gloves. Gloves do not protect you from the primary beam. So if you actually are holding an animal and your gloved fingers are on the beam, you are actually receiving quite a dose to your fingers. Just something for everybody to remember. The principles set forth by the U.S. government for radiation safety, there are numbers available, but what they would like everybody to remember is ALARA. And what ALARA stands for is as little as reasonably achievable. And what that means is to try and use time, distance, and shielding in order to minimize one's exposure. So we're going to move on to actually talking about interpretation of films. And first thing I'm going to start with are radiographic opacities. We've touched on this a little bit. This has to do with how much of the X-ray energy is attenuated by the patient, depending on what tissue type it is. There are 5 basic radiographic opacities. Air, which is the least attenuating and appears on radiographs as black. Fat, which is a light gray color. Water, which includes soft tissues, muscles, heart, liver, anything that's water-based is a medium gray. Bone, which you all know is white typically. And then metal, which has the highest atomic number and physical density, and therefore attenuates the most energy, and it appears as white on a radiograph. In addition to knowing these 5 opacities, we have to know the signs that are used in radiographic interpretation. There are also 5 basic Röntgen signs. Röntgen was the man who discovered X-rays in 1896 by accident. And so in his honor, the 5 means of evaluating an organ are named after him. What you have to consider doing, first thing, is looking at the number and location of organs. You also have to evaluate their size, their shape, their opacity, which is taking into account the 5 opacities we just discussed, and then their margination. Radiographic interpretation, there are a number of things that will provide you or lead you to a correct answer instead of leading you down the wrong path. And the things you have to take into account when you're interpreting radiographs, the first thing is the signalment and the history. And what you would like is an accurate signalment on the patient. You'd like to know if it's a female dog, if she's spayed or not, for example. And then you'd also like an accurate history whenever possible from the owner. So on these Navli's examination questions, it's very important to read the questions for these details. The next step is you'd like a physical examination that is thorough, because what you want to make sure is you're actually radiographing the correct part of the animal. You don't want to be radiographing a pelvis because you presume, because it's a German Shepherd, that it has hip dysplasia, when in reality it actually has a cruciate ligament injury in its stifle. After you've obtained the radiographs, you have to be sure that you have a diagnostic film, which means that you need to look for correct positioning and correct technique. You neither want a film that's too white or a film that's too dark, because that's going to lead you to potentially misinterpret your findings. And then what I'm going to emphasize throughout the rest of my talk is being systematic. So deciding what your organ or regional approach is going to be to interpreting radiographs. What are the pitfalls of radiographic interpretation, and what do you want to be sure that you're not doing on the Navli exam or in practice? First, you don't want to stop at the obvious lesion. If you palpated the dog and you think it has a splenic mass, what you don't want to do is then not look at the rest of the film and potentially miss the nodule in his chest that may indicate he has metastatic disease. In this case, as an example, you found the lesion that answers your clinical question. You may, again, miss the abnormalities that are on the edge of the film, or may miss the fact that the serosal detail is decreased, which suggests that he actually has some fluid free in his abdomen. And then, finally, one of the big errors people make is that they can actually try and make the abnormalities that they see fit their suspicion of what's going on clinically, instead of describing what they see and then making a list of possible rule-outs. So I'm going to start with musculoskeletal radiology, and as I alluded to earlier, the systematic approach is what's key to making an accurate diagnosis. There are a number of different ways of doing it, and that's something that obviously everyone has a choice about what they do. The two most common are reading from inside out and outside in. Inside out means that you start at the stifled joint or at the joint itself, then you read the margins of the joint and then the margins of all of the bones, and then finally the soft tissues. Outside in is exactly the reverse, starting at the soft tissues and reading in. Again, don't forget the soft tissues because they sometimes can give you a hint as to which limb the lameness is in because one side's thinner than the other. Or you can have a lymph node enlargement on the edge that might give you a hint. Then, with musculoskeletal radiology, it's important to know what occurs where commonly. Because different species have different diseases, and they occur in different places, that's something that you really need to set straight in your head. A particular example is osteochondrosis, which the distribution is very different in the dog than it is in the horse. Labeling conventions, this is just going to help you tell, if you can't tell by the anatomy, which is lateral and which is medial. Just to remind you that films are named for the direction of the beam, so a ventral dorsal projection of the thorax, the beam is going from the ventral aspect of the animal to the dorsal aspect of the animal. The left and right markers are placed on the lateral aspect of the limb. If it's a true lateral, then the markers are placed cranial or dorsal. On obliques, the same thing is true. It's named from point of entry to point of exit. So you're going to see this most commonly in horses, and you'll see them named by their letters. Dorsolateral palmaro oblique, and that means the beam went from dorsolateral on the limb to palmaro medial. But what's important to remember is the part of the limb that's actually highlighted are the opposite quadrants. So if you think of the leg as a square, it's going to go from corner to corner, but the other two corners are what's going to be highlighted on the radiographs. And the way to think about that is if you take the first letter and the last letter before the O and put them together, and then the two middle letters, that's going to tell you which parts of the limb are actually highlighted. So getting on to abnormalities of bone, the key in bone is to decide if there's too much or too little bone, and then whether or not, if there's too much, whether it's an aggressive lesion or a benign lesion. So to determine if something's aggressive or what are the characteristics of aggressive bone lesions, osteolysis and bone production are the characteristics. The appearance of this osteolysis and new bone formation is what's going to key you off to the degree of aggressiveness of the particular lesion. So if we look at just very aggressive lesions, such as a primary bone tumor, primary malignant bone tumor in a dog, then you're going to see permeative or moth-eaten osteolysis, which are little holes or just slightly bigger holes with irregular margins being punched into the bone. We'll also have, as I said, indistinct and poorly defined margins to this area. Typically, you're going to have a medium to long zone of transition to normal bone in the limb. And the new bone that's formed, instead of being smoothly marginated and of similar opacity throughout, is going to be amorphous in appearance and going to have a variable degree of mineralization. So just as an example, this is a synovial cell, or this is an osteosarcoma You can see it's occurring in the distal femur, and there's actually a oblique lucency that is consistent with a pathologic fracture. If you notice in the distal femur that there's actually a mix of increased areas of opacity and areas of decreased bony opacity, suggesting osteolysis. This is a osteosarcoma, which is the most common bone tumor of the dog, and it's occurring in this particular case in one of its common sites, which is towards the knee. What's important to remember is that this question is given to you on the NABLE examination, and they expect you to decide what to do next for this dog, whether to put a plate on this dog or to recommend amputation. You need to have looked carefully in order to detect the increased bone and the areas of osteolysis in order to come to the correct answer, which is amputation. This is another example of an aggressive bone lesion. This is a synovial cell sarcoma, so this is a tumor actually of the synovium surrounding the joint. And you can see there's increased soft tissue opacity surrounding the distal femur, and then the patella is nearly gone. There's just a few streaky small areas of mineralization on the cranial margin of the soft tissue swelling, and then the entire distal femur is lucent with variable areas of mineralization. You can also see that there's a square, chewed out portion of the tibial plateau of the proximal tibia. So this, unlike the osteosarcoma we just saw, actually is affecting more than one bone, so you might think that this actually is an infectious process. But in the joints of a dog, the most common cause of an appearance like this is a synovial cell sarcoma. Just one more aggressive bone lesion. They can occur in the axial skeleton. They don't only occur in the appendicular skeleton. And what we see at this lumbosacral junction is discospondilitis. Discospondilitis is an infection of the intervertebral disc. It's hematogenous in origin, most likely, and the radiographic signs are the irregular end plates of the vertebrae, which is the bone facing the intervertebral disc space. They will have an irregular contour in areas of lucency, which you see in this case. There's also a sclerotic appearance to the bone surrounding those lucencies, suggesting that the vertebrae are trying to, or the bone within the vertebrae are trying to wall off the infection. And then you can see at the ventral caudal aspect of L7, there's also some irregularly marginated, sort of variably mineralized new bone formation. This is another good NABLE question because discospondilitis, first you need to know that it's an infectious process. You need to recognize that it's probably not a tumor because it's affecting both sides of a joint in the spine. And then also need to know the agents that cause this. Most common is Staphylococcus aureus in the dog. This is a disease that primarily occurs in the dog. But other things can cause it, and one of those things is brucella, which is a zoonotic disease that can be spread to you and I. Benign bone lesions, on the other hand, typically have either no osteolysis or they have large lucencies that have nice, smooth, sclerotic margins. They, unlike aggressive bone lesions, have short zones of transition to normal bone, and the new bone that's formed is going to be solid. It's going to be very well mineralized, and it's going to look very quiescent in appearance. So we're going to go on. This is actually a benign bone lesion. This is a navicular fracture. This is a skyline projection of the palmar processes of a third phalanx. And the flexor cortex of the navicular bone is actually centered in the middle of this picture. And what you can see is that there's a lucency, a line that is approximately 2 to 3 millimeters wide that extends through the navicular bone at one of its margins. This has a nice smooth margin. It doesn't have any evidence of bone destruction. So this is probably a lesion that's benign in origin. It does not probably represent an infection. What's important in horse radiology? The key in horse radiology is to know your anatomy. Because you need to know what soft tissue structures are located in the area, how they're going to be affected by the bony lesion, and what that abnormality is going to do to affect performance. The other thing that's important to consider in the horse are common etiologies for musculoskeletal disease. And if you think about what occurs in horses, they can get infectious causes if they're a foal or from trauma. They have a large portion of developmental abnormalities, particularly in the racehorses. They're very prone, as I just said, to traumatic injury, running into fences, running into trees, cutting themselves on wire. And then as they're used as performance animals, they're prone to degenerative joint disease, just like a human athlete would be. So musculoskeletal infections in the horse, they tend to be aggressive in appearance. In foals, it's most likely secondary to sepsis from failure of passive transfer of the antibodies from the mare to the foal. If they're a little bit older, this infection spread throughout their blood, can actually seize the feces, and they can get septic fasciitis. If they're adults, the most common cause of infections are trauma, so they have a penetrating wound, or iatrogenic from a joint block or something else that we did as veterinarians to introduce a bacterial species into a place it's not supposed to be. This is actually a dorsopalmar projection of the distal portion of the cannon bone, and what you can see is there is a soft tissue swelling along the lateral margin of the limb. There's a smoothly marginated bony exostosis that has a lucent tract in it, and within that lucent tract is a small piece of very opaque bone. This actually represents a sequestrum. The lucent zone surrounding it is an involucrum, and the hole out to the surface is the cloaca, where the abscess surrounding the piece of non-vascularized bone is draining to. This is often, or can occur, secondary to things like wire cuts in the horse. Equine osteochondrosis, the common sites I've listed here for you. This is something, when you look at your video, look carefully at the circled area. There's a small bony fragment that's originated from the distal intermediate ridge of the tibia. This is a common site. The thing to remember to do if you identify an osteochondrosis in a lame limb is to radiograph the contralateral limb, because these lesions can be bilateral, and that's something that may appear actually on the NAVLE exam as an option of what you need to do next. Stress remodeling or degenerative change secondary to work occurs very frequently in the racehorse, and most common things to see are carpal chip and slab fractures off of C3, but abnormalities of the cannon bone and sesamoids are also fairly common. Also traumas, and kicks, wounds, etc., is another common cause of stress remodeling in the horse. And again, that's something more you're going to see in the little kid's horse than you're going to see in the race horse. DJD, or degenerative joint disease in the horse, is very common because we ask them to do things that they weren't necessarily designed to do. And the tarsus, you'll see the DJD changes commonly in the working horse. So the cutting horse, the dressage horse, the hunter jumper. And it manifests itself initially by osteophyte production, which you can see it's on the inset on this horse at the tarso-metatarsal joint. And then it progresses from there, and this is quite a bad case, an active case of DJD in the tarsus, where there's actually an irregular margin to the joint, and a portion of the joint is actually collapsing or ankylosing. The tarsal joint, just for your information, is one of the places that DJD can have a more aggressive appearance. If you were to see this in another joint in the horse, you would worry that it was infected, but in the tarsus, this is purely a degenerative change. Carpus, as we just spoke of, in the racehorse, and then there are a number of other places that you can get DJD, including the distal interphalangeal joint, which the lay term for that is ring bone. So we're going to move on to small animal musculoskeletal radiology, and you can see that the list of things that cause abnormalities in the dog and cat is much longer. The important things that have been added are neoplasias and immune-mediated diseases, which are very uncommon in the horse, but much more common in the dog. A little less common in the cat, but do exist. The other thing that we need to take into consideration in the dog and the cat is that we're much better able to examine the axial skeletal system than we are in a horse, which is, because they're so large, it's quite difficult to get adequate x-rays of their spine or their pelvis. So we'll start with canine developmental diseases, of which there are many. I think these are fair game on the NABLE examination. The big one is panosteitis. This is a dog that's going to have shifting leg lameness, pain on palpation of his long bones, and radiographically what this is going to appear as is increased fluffy opacity in the medullary portion of a long bone diaphysis. Hypertrophic osteodystrophy is a giant breed disease or large breed disease of unknown etiology. Nobody knows what actually causes it. These are dogs that come in febrile, painful, not eating. And radiographically what you'll see is a double physeal line, typically in the distal radius and ulna. And you'll also perhaps see some periosteal new bone forming in this area if it's a more chronic case. Osteochondrosis, common in the dog, not common in the cat. Elbow dysplasias, probably all a manifestation of incongruity in the elbow, commonly seen in the Labrador, can be seen in other giant breeds. But there are different manifestations of elbow abnormalities in the young dog. You can have an ununited anchineal process, a fragmented mediocoronoid process, or purely a incongruency. This is something that I would recommend you actually look in Thrall to go over more specifically, because I think this is a fair game. Important to remember, ununited anchineal process, typical or is seen in the German Shepherd, and your anchineal process should be closed by 20 weeks or 5 months. And then finally, hip dysplasia, which is every owner's worry with a large dog, and obviously too big of a topic to brush on in this lecture. I'm going to try and just touch on the important topics that may come up on the licensing exam. So this is a dog with panosteitis, and you can see in his left femur he has an increased medullary opacity when you compare it to the other side. This is a typical appearance of panosteitis. It's also a good dog to evaluate his hip joint conformation. He's got adequate coverage of both femoral heads by his acetabulum. We want at least 50%. He's got a fairly congruent appearance to the joint, where it's not wedged in one area and parallel in another. And he doesn't have any evidence, or she, I should say, doesn't have any evidence of DJD at this point. This is a young dog, so it may be too early to see the arthritis forming, but it is a possibility. So canine osteochondrosis in the dog, the sites are going to be different in the dog than the horse. And just to remind you of its etiology, it's a failure of the endochondral ossification. The most common place in the dog is the caudal margin of the humeral head, and what you're going to see there is a flattening or flapping of the cartilage in that area. This can be seen in golden retrievers, Labradors, other large breed dogs, but also in the border collie. And I've listed some other common places for OCDs or OCs to occur, and just need to remember they're common places, breeds they occur in. Hip dysplasia I just covered briefly for you. The parts that you need to remember is that a dog with dysplasia is going to have laxity of those joints. They will have less than 50% coverage of their femoral heads. Often they have subluxation of their femoral heads. They'll have an incongruent articular space. You'd like to have nice parallel lines between the femoral head and the acetabulum. The acetabulum will be shallow, which goes along with the less than 50% coverage. The two things that potentially may be discussed or asked on the NABLE in terms of rating hips. The first one is pen hip, which is a more dynamic study. It can be performed at any age, but typically starting at 6 months. And what it does is it looks at the degree of joint laxity within the hips using distraction, and compression views. OFA projections of the pelvis cannot be certified until the animal is 2 years old. That is also true of elbows, and that's definitely I think, fair game on this exam to expect you to know that. Small animal appendicular neoplasia. It's an aggressive bone lesion. It's fairly common in the dog, much less common in the cat. And 85% of the appendicular neoplasias that you're going to see in practice are going to be osteosarcomas. There's the clinical idiom of away from the elbow towards the knee to help us remember where these typically occur. Two most common sites are the distal radius and proximal humerus. These tumors typically do not cross joints, typically only occur in one bone, but neither of these are steadfast rules that this tumor obeys. So I'm going to go on to thoracic radiology now. This is a big topic again, and the key here is that you need to be systematic. That's going to help you to arrive at the correct answer and be sure that you're not missing anything. Same thing holds true. Are you going to read from inside out or outside in? The way that I read it is I read my heart first, then the vessels, then the lungs. Then I look at the mediastinum, pleural space, chest wall, and then everything surrounding it, abdomen, neck, whatever else is on the film. The important thing, like I said, in musculoskeletal is you got to remember to use the same system all the time. That way you'll be sure that you're not skipping things like the pleural space every time you read a thorax. Like I said, we'll start with heart. That's where I start. This is a lateral projection of the thorax, and I've just outlined for you the places that the different parts of the heart are located. The left atrium is seen at the dorsal aspect of the colocardiac silhouette. You can see it outlined there. When it becomes enlarged, it causes dorsal deviation of the trachea towards the spine. The angle becomes more parallel. If you have enlargement of the left ventricle, just ventral to that, that's a more difficult call, but sometimes you can identify straightening of the colocardiac silhouette. Enlargement of the right ventricle is going to cause increased sternal contact, or more of the heart will be in contact with the sternum. And then finally, if you have enlargement of the main pulmonary artery, the aorta, or the right atrium, the bulge is going to be evident at this site, and it's difficult to differentiate on the lateral. So what you need is actually the ventral dorsal to identify which one is enlarged. For reading the heart on a VD or DV, the analogy that's used is a clock face. First thing to remember is that the radiograph must be straight, because if it's not, it's going to alter the pattern of bulges. And secondly, that the bulges at any particular area actually indicate chamber enlargement. So if we have an enlargement at 12 o'clock, that's going to be an enlargement of the aortic root, typically seen or commonly seen in aortic stenosis. If you have enlargement at 1 o'clock, that's going to be enlargement of the main pulmonary arterial segment, most commonly going to be seen, particularly in our case in Florida, in dogs with heartworm disease. Sort of from the 2 to 3 o'clock part of the heart, if there's a bulge there, that's going to be the left auricle. The left auricle is only going to get big if the left atrium already has. Left ventricle, just like the lateral, is very difficult to tell enlargement. It's a fairly non-specific finding. Left atrium can be quite easy because you can use the main pulmonary or the main stem bronchi in the caudal thorax to actually outline where the atrium is located. So typically you have a nice V-shaped appearance to the main pulmonary, to the main stem bronchi. If they become more U-shaped or cowboy, like a big bow-legged cowboy, then you need to worry that this dog has left atrial enlargement. And then rounding of the right cardiac silhouette is going to be consistent with enlargement of the right atrium and right ventricle, which typically all go together. Dogs have tremendous breed variation. We all know that. since they're all the same species, all the way from the Great Dane to the teacup poodle. And along with that goes their difference in chest conformation. The deep-chested dogs typically have a small upright heart, versus the brachycephalic dogs, such as the bulldog, that their heart looks huge in comparison to their thoracic size. There are some basic rules to follow, and I've listed those up here for you, and they're a good place to start, but you always have to remember whether or not a dog is a big, tall, lanky Irish setter or whether it is a little squat bulldog. Just to illustrate, you can see the difference in this case. We have a thin greyhound on one side and a big bulldog with an unusual appearance to his ribs because he has multiple vertebral anomalies. So you can see that there's quite a wide range, and that it can be easy to give a brachycephalic dog cardiomegaly when in fact they don't. Cats, on the other hand, are a little bit easier. There's very little variation in their size, so there's very little variation in their cardiac appearance. Two things that can actually change how you evaluate cat hearts is, one, pericardial fat, especially in our sedentary house cats, can give you the impression that they have cardiomegaly. And you just need to look very carefully at the edge where you can actually differentiate pericardial fat from the soft tissue of the heart. The other thing is you can look at the back fat on the cat or on the sides of his thorax to help you identify that it's an obese cat. The other thing is that old cat hearts tend to lie down. They tend to get more horizontal, and you'll see this on the lateral projection where the heart will appear to be totally horizontal in the thorax, and this is a normal aging change. The other aging change that goes along with this is that I actually can get a redundant aorta, or the aorta can appear to be slightly wavy. And again, this is an old cat change. I've gone through on the next two slides and talked about the enlargements you're going to see with different congenital cardiac diseases. And I'm not going to go through these, but I think the ones that are important to remember is that VSDs are very common in the small animal patients. And VSDs, what you're going to see is pulmonary overcirculation, or too much blood in the pulmonary vessels, and usually a generalized cardiac enlargement. The other common cardiac anomaly that we're going to see is the PDA, and this is one that has a characteristic radiographic appearance of a triad of bulges, meaning it has an descending aortic bulge on the VD, an MPA bulge, and a left auricular bulge. And that's one that you may be asked to identify. They're also going to have a machinery murmur and bounding pulses, and they also will have large vessels in their radiographs that will help you to identify that that's the abnormality. Here, much less common, but what's important to remember is atrial septal defects are typically normal in appearance. And the way you remember these enlargements of chambers is by thinking about where the blood flow is going. So it's always going to go from high pressure to low pressure, and that's going to help determine where the chamber enlargements are going to occur. So the next thing is, again, another list of acquired diseases. I guess the only three that I'm going to talk about in the dog are endocardiosis, which is very common. That's the myxomatous change to the AV valves in the dog, most commonly in the mitral valve, and it's most commonly in small breeds such as poodles and Yorkies. They're the ones you're going to see with the big, huge left atriums and the cowboy legs on their VD. Pericardial effusion, on the other hand, is going to give you the globoid heart. It's going to give you the big basketball heart. And that's just important for you to identify because that's a dog that needs immediate intervention. Heartworm disease, probably pretty common if you've been in Florida or any subtropical area for any length of time. They're going to have the characteristic reverse D of right atrial and ventricular enlargement and an MPA bulge. And then with all of these, it's important to remember that you need to evaluate whether they're compensated or decompensated, meaning whether their heart still has adequate function so that they're not in cardiac failure, or they haven't developed ascites or pulmonary edema, depending on which side is failing. Just a pericardial effusion dog, so that you can have a reminder of what it actually looks like. It's the big globoid heart with the rounded margins. It has, its trachea is parallel with the spine on this case. It takes up a large portion of the thorax and silhouettes with the diaphragm. The other disease that can have this appearance is dilated cardiomyopathy, particularly in the Great Danes and other giant breeds. But this is a dog that needs to have an echocardiogram sooner versus later, because pericardial effusion is a potentially life-threatening disease. Feline cardiac disease, on the other hand, is fairly limited to the congenital abnormalities that I listed earlier, and in the young animal, and then limited to really only one disease and its variations currently in the older animal, and that's hypertrophic cardiomyopathy. This is a disease that can be detected easily on radiographs by its biatrial enlargement. Characteristically, they have a valentine appearance to their heart on their VD projection, such as this cat. And since taurine has been added to diets, we don't see dilated cardiomyopathy very commonly, but it is indistinguishable from hypertrophic cardiomyopathy on radiographs. Again, what's important to remember is whether or not the animal is in failure or not, because that's going to change how you're going to treat them. If they're in failure, they obviously need a diuretic sooner versus later, versus if they're not in failure and can wait a week for the cardiologist to come and do an echocardiogram. This is a cat that you can see that his ventral cardiac silhouette is obscured on this lateral projection by a soft tissue opacity. He's also got some widening of the silhouette and dorsal displacement of the trachea. There's a patchy, dense interstitial pattern in the caulodorsal lungs, so that you can't see the columella cava well. And then his cranial abdomen appears to be pendulous and with poor detail. So this is a cat that probably has hypertrophic cardiomyopathy, pleural effusion, pulmonary edema, and maybe even some ascites, and is actually in heart failure. What's going to help you to determine whether an animal is in heart failure or not? That's looking closely at the pulmonary vasculature. It's also going to help you to determine the etiology of the cardiac anomaly or bulges you're seeing on the radiographs. So on the lateral projection, you're going to examine the cranial lobar vessels. They should be no bigger than the fourth rib approximately. On the VD and DV, you're going to look at the pulmonary vessels as they cross the ninth rib. Normal is 1/2 to 1 times the width of the rib at the intersection. It's important to also evaluate the course, whether it's tortuous or blunted, and then how nicely the vessel tapers. So increased veins. If you remember it, goes artery bronchus vein, dorsal to ventral on the lateral, and artery bronchus vein, lateral to medial on the VD. Veins, if they're too big, by the standards I just relayed to you, suggest that that animal is in left-sided heart failure. This is a dog that you can see has dorsal displacement of his trachea. He has a large left atrium and straightening of the cardiac silhouette. He also has increased opacity in his perihilar region, which is the typical place, unlike the cat that we just saw, dogs get pulmonary edema. That's the first place that the pulmonary vein pressure becomes so high, and it's the first place they leak. It's right near the hilus of the heart. In the cat that we saw, you saw that it had a more patchy, uneven distribution. If you have increased arteries, and this is an arteriogram, it's actually probably a non-selective cardiogram, just to outline the arteries for you, you can see that the arteries are hugely dilated, especially the left caulolobar artery. Most common cause that we'll see in Florida is heartworm disease. Other causes that are less common are PTE, or pulmonary thromboembolism, and that's proximal to where the thrombus is lodged. Will there be dilation? and then pulmonary hypertension in the animal with long-standing pulmonary disease. If you have your arteries and veins too big, the first thing is that you may have a left to right shunt or pulmonary overcirculation. If you've been fluid resuscitating this animal, or it's not been eating and drinking and you've been actually giving it IV fluids, then it may represent an iatrogenic overload. And then some cats that are hyperthyroid, and sometimes their high cardiac output leads to increased arteries and veins, much less common though. What if you have decreased arteries and veins, if they're smaller than a half of the rib? Then you could suspect, depending on the bulges within their heart, that they may have a right-to-left shunt, such as a right-to-left PDA or a tetralogy of Fallot. That they may have right heart output failure. Right heart output failure is a diastolic failure, so it's a failure of filling of the heart, and that's most commonly seen with pericardial effusion. The most common cause of decreased arteries and veins is hypovolemia, so dehydration, either from vomiting and diarrhea or shock, such as in a hit by car dog. You can see this in Addisonian dogs, and then in severe pulmonic stenoses and PTE, this time distal to the thrombus. We're going to move on here and talk about the ever-confusing lung patterns which everybody struggles with. The first thing about lung patterns that you need to do is look at the distribution. So you need to look at whether it's a focal lesion, whether it has just one nodule and one lobe, whether it's lobar, whether he's got an alveolar pattern in his entire right middle lobe, whether he's got multiple opacities in his lung, like multiple nodules, or whether it's a diffuse increase in opacities, such as in a miliary interstitial pattern. From there, you want to classify how severe the changes are. Are they mild, moderate, severe changes that you're identifying? You also want to look for concurrent abnormalities. Do they have a pleural effusion? Do they have a heart problem? Do they have something else that's going to help you answer the question of what's causing this increase in pulmonary opacity? And the systematic approach to lungs that I use is I actually trace each lobe entirely on each projection. And it's a good practice to get into because, one, it'll help you to identify where the margins are and where the pleural fissure lines will occur, but it'll also remind you to look at the entire structure of the lungs. So you can have diffuse lesions of the lungs where the lungs are too black or too lucent. And it's either because you have too much air in the lungs or too few vessels. Too much air in the lungs is most commonly because of an emphysematous change. They don't get emphysema like people do. A lot of the time it's a congenital abnormality where they have the cartilage of their bronchi and bronchioles is malformed. The other time is if they have a compensatory increase in lung volume because they've had a previous lobectomy. And then probably the most common place to see lungs that are too black is in the cat with asthma. And that's sometimes all you're going to see. Again, hypoperfusion, hypovolemia, not enough vessels will lead to the lungs looking too black as well. So if the lungs are too white, why is it that they're too white? Is it because there's too many vessels, or because they have infiltrative disease, or because they are not able to expand their lung lobes as they would normally? So atelectasis, or collapse of a lung lobe, can cause the lobe to be too opaque. It can be caused by a large number of things, the primary ones being upper airway obstruction, or air or fluid surrounding the lobe. It also can be caused by an animal that's been recumbent for a long period on one side, actually just deflating the lobe. As I alluded to just a bit ago, lungs can be too opaque because they have too many vessels. And this is most commonly seen in dogs with patent ductus arteriosus, where they actually have dilation of their arteries and veins. And what it means is you can actually see the small little peripheral arteries and veins better than you can normally. And then finally, which is what we're going to go on to next, is talking about infiltrative disease. which is what's most commonly going to make a lung too white. So interstitial pattern is the broadest category because many, many, many things can cause an interstitial pattern. Interstitial pattern is defined by, or its etiology is that it's caused by an infiltration of fluid or cells in the connective tissue framework of lungs. So with lung patterns, it's very important to remember the pathophysiology behind them because that's going to help you to determine this radiographic appearance. So interstitial pattern characteristically is, has three basic patterns: a linear, a nodular, and a miliary. Linear tends to be an unstructured pattern that's hazy. There's just an overall increase in opacity either in a single lobe or a number of focal spots or in the entire lung. But the important factor to decide whether or not it's interstitial or not is that you cannot see the margins of the pulmonary vessels clearly. Nodular pattern is, as you would expect, it's a structured pattern where the animal actually has multifocal, multiple round nodules within their lungs. They typically need to be bigger than 5 millimeters for us to perceive them. And then the last pattern is a miliary pattern that is a diffuse pattern of pinpoint nodules, very small nodules throughout the entire lung that actually makes the chest too white, much less common than the other two are. This is actually a linear interstitial pattern, and common causes, or the most common causes, are fibrosis. It's just an aging change in the older dog in particular. You can have pathologic fibrosis, or you can have mineralization present within the pulmonary parenchyma. It's commonly seen with interstitial edema or hemorrhage or viral pneumonia. Unfortunately, the list of what causes a linear interstitial pattern is very, very long. So what's important for you to remember is that it blurs the margins of the vessels, so you cannot see the vessels sharply in this caudal dorsal lung field, and that you need the history in order to help you get to the answer in the more severe cases. Nodular patterns, on the other hand, are a little easier. They're a little bit shorter list of things that might cause them. But what you need to remember is that it's not always metastatic neoplasia. So if you see a dog that has multiple small centimeter in diameter nodules in its chest, it does not necessarily need to be euthanized. It could have a fungal disease such as blastomycosis if it comes from Georgia or some other part of the Midwest. It could have pulmonary infiltrate of eosinophils secondary to heartworm disease. And in the cats, it actually can be a primary pulmonary neoplasia presenting as multiple nodules. This is a dog you see has multiple small nodules in the inset throughout its lungs. You can also identify that he has increased opacity in his perihilar region. This is a dog that had blastomycosis from southern Georgia. Bronchial patterns. This is one of the more difficult patterns along with interstitial for everybody to get a handle on. And again, the key is to remember what causes this pattern in the lungs. It results from infiltration in the bronchial walls. The bronchi are outlined by air, both inside and outside, and typically their walls are very thin. When they get cells or inflammation in those walls, the walls get thicker, so that you're able to now see them as discrete structures. And the common descriptions you'll read or hear is donuts and railroad tracks. Donuts are cross-sections, as you can see under the mid portion of this rib, of thick bronchial walls. Okay, so it looks just like a donut that you get at, Dunkin' Donuts. Railroad tracks actually are longitudinal cross-sections of that bronchi, and they're just, the wall looks too thick and it's too irregular. It's not the nice thin stripe that you typically see. Again, this is a pattern with multiple causes, depends on the severity, and things that commonly cause it include allergic or parasitic disease. You can also have an infectious bronchitis, but you really need more information to help you get to the answer. as to what might be the underlying etiology. Alveolar pattern is probably the easiest to identify and probably has the shortest list of differentials. And an alveolar pattern results when infiltrate, either fluid or cells, fills the alveoli or air sacs. Or it can occur, like we've discussed earlier, if the alveoli deflate and there's atelectasis. This is an alveolar pattern in this inset, and what you can see is that there are tubular black structures, which represent the bronchi, coursing through a lung that's too opaque. What we can't see in this image is any vessels, which means that this is not an interstitial pattern and has crossed over into an alveolar pattern. So characteristically, it's going to be a homogeneously opaque area with air bronchograms, as they're called. It can occur in a patchy distribution, and thus the distribution is what's going to help you sort out the differentials. So three big things cause alveolar patterns in the lungs of any animal. The first is that you have pus. So you have a pneumonia of some kind or an infiltrate of inflammatory cells. The second is that you have edema, either cardiogenic, meaning in the dog a perihilar infiltrate that extends outward, or in the cat a patchy infiltrate. Or you can have a non-cardiogenic edema, which is a distribution typically in the cat or dog is caudal dorsal, and this is commonly seen in animals that have had multiple seizures, animals that have had near drowning, animals that have had near electrocutions, and nobody's quite sure why this pattern manifests itself, but it's important to recognize when you see it because it's going to influence your treatment protocol. You can also see an alveolar pattern if they have hemorrhage throughout their lungs, like if they've been exposed to erythrocyte or they're in DIC. And then also you can have an alveolar pattern in neoplasias late as the nodules all coalesce. So why is this such a perplexing area for everybody? Well, because most of these patterns are mixed. So what do you need to do on the NAVLE exam? Well, one, you have to remember that these are going to be fairly obvious examples. So you're going to need to identify the predominant pattern that's present in the radiograph. Then you need to identify the lungs and the portions that are involved. So as in that case we just saw, it was the right middle lung lobe in the periphery that had an alveolar pattern. What we know is that that's a typical distribution of a aspiration pneumonia. So if we find a peripheral alveolar pattern in the cranial lobes or the right middle lung lobe, the first thing we need to think is that it's a aspiration pneumonia. Then we need to note the severity, and that's more important with interstitial and bronchial than alveolar, because alveolar by definition is a fairly severe process. We also need to be sure that we look at the concurrent cardiac and pleural changes that may help us to identify what's causing the underlying pattern, and then also remember that the vascular changes may help us to identify what the nature of the cardiac disease is. And once we've done all this, then we can create a rule-out list using our Dammit scheme in order to come up with the most likely cause of what we're seeing. Can't forget that there are other structures in the thorax. We tend to spend a lot of time looking at the heart and lungs, but don't forget there are a lot of other structures there, including the big vessels like the cranial vena cava and the caudal vena cava, the trachea and the bronchi, which can become dilated or have foreign bodies within them, the esophagus, which is quite prone to abnormalities, including megaesophagus and foreign bodies, and then the lymph nodes. And the big key is to remember that the sternal lymph node, which sits just dorsal to the second sternobra, drains the abdomen and not the thorax. So if you see sternal lymphadenopathy on an animal that you don't suspect lymphoma on, you need to go look at that dog's abdomen, because it may be that the primary disease is originating there. Just to remind you, one of the common mediastinal abnormalities is a megaesophagus. The radiographic changes you'll see in an animal that has not been administered barium includes the tracheal stripe sign, where you can actually see both margins of the trachea. You can actually see the thin walls of the air-outlined esophagus in the caudal thorax. And as in this case, if you're suspicious, what you can do is go ahead and feed them a barium meal and identify that the esophagus is in fact distended. There are multiple causes of megaesophagus, and I'll leave you to look that up. Much more common in the dog than in anybody else. So the pleural space, another place that we typically are going to forget, just like the peritoneal detail in the abdomen, but the pleural space is a potential space that typically has a small amount of transudate in it that lubricates the two pleura as they glide against each other. Abnormalities of the pleural space is if you see retraction of the lung lobes, or the aerated portion of the thorax, away from the thoracic wall, either by air or fluid. And you wonder, how can you tell if it's retracted by air? Well, one, you can see the lung margin typically, and two, what you're going to do is trace the vessels. And if you can't trace the vessels all the way to the thoracic wall, they may in fact have a pneumothorax. You can also look to see if the heart is elevated off the sternum in a pneumothorax by air, or if the heart silhouettes with a soft tissue opacity with the sternum, which suggests they have fluid. You may have rounding of the lobes in chronic cases, and you can actually have pleural masses that just are soft tissue, broad-based masses that arise from the pleura or the ribs. So pleural effusion, just an example, some rounding of the lobes, soft tissue opacity dissecting between the lung lobes and the inset, many causes of pleural effusion, and the easiest way to get your answer is to actually go ahead and tap some of this fluid off and submit it for evaluation. Chest wall, we want to make sure we evaluate the skeletal structures. We want to look at every rib. We want to look at all of the spine. Most common abnormality you're going to find are healed rib fractures, or concurrent rib fractures, or new rib fractures. New rib fractures might help you in an animal that you aren't sure what happened to it to identify that it's had trauma. But if you actually see an aggressive bone lesion in a rib, which does occur, you just need to remember that the most common tumors are osteosarcoma and chondrosarcoma. Again, this is the dog's disease. They also can have metastatic lesions or metastasis of carcinoma in their ribs. And then finally, you don't want to forget to evaluate the cranial abdomen, because you may get a hint that there's some abdominal disease going on and that you need to further evaluate the abdomen with radiographs or ultrasounds. So just like everything else that I've discussed today, I want to emphasize to you all to be systematic. The way I read abdominal radiographs is I read from left to right. So I read it like it's a book. So I start with the lung, then I look at the diaphragm, the liver, stomach, etc. What I always forget, and what everybody always forgets, is to evaluate the retroperitoneal and peritoneal detail. And I'm going to harp on this a little bit, but missing free air is a fatal mistake. That dog is going to die. That cat will die if he hasn't had surgery recently. So, serosal detail. There's both peritoneal and retroperitoneal. We're going to talk about them differently. So increased serosal detail, and you can see the top one is a cat that actually has air outlining all of its abdominal organs. That's what causes increased serosal detail. It's because you now have a means of producing contrast in a primarily soft tissue and fat body cavity. Again, it's a fatal error to miss it in the dog that's vomiting, because it means they probably have peritonitis, or at least they have a rupture that is going to progress to peritonitis. And just a reminder that postoperative air can persist for up to a month. If you have any concerns, if you see the unusual gas bubble outside of the GI tract, or the gas dissecting between the liver and the diaphragm, which are the typical places to identify them radiographically, what you need to do is go ahead and put the dog in left lateral recumbency, and if you have the potential, is to shoot across the dog and across the table. Because what will happen is the air will float up to the top and will outline the diaphragm as you see here. So with the lungs on one side and the air, free air in the abdomen outline both sides of the diaphragm. And then you can actually see the liver lobes being outlined and that's sort of the rounded structure right underneath the ribs. Decreased serosal detail, on the other hand, is what may happen once this actually ruptures, and once they are into having peritonitis. But there are a lot of causes of decreased abdominal serosal detail. And these include any type of effusion, so blood, urine, transudate from liver disease. You can also see a decrease in your ability to identify the margins of organs because they have metastasis throughout their peritoneum or mesentery. It's most commonly seen with carcinomas, particularly things like pancreatic carcinoma. And then, as I alluded to a little bit ago, peritonitis, or inflammation of the peritoneum, is a very common cause of decreased serosal detail. Once you're getting good about remembering to evaluate your peritoneal serosal detail, you need to evaluate your retroperitoneal detail. And that is the area where the kidneys, adrenals, ovaries, aorta, column vena cava live. If you have a pneumomediastinum, like you would have a dog that gets a bite to his neck, and he's got gas dissecting through all of his skin, under his skin, down through the fascial planes of his neck, all around his heart and great vessels and trachea and esophagus, that gas can actually migrate into the cranial abdomen in the retroperitoneal space. If they have a loss of retroperitoneal detail, which can be caused by an increase in soft tissue, then there are a number of different things, just like peritoneal detail, that can cause this. You can have hemorrhage. That's most commonly seen in dogs that are hit by cars. They'll have retroperitoneal hemorrhage. What you won't be able to do is see the renal margins. You'll have increased soft tissue opacity. You won't be able to see the fascial planes and fat all through the retroperitoneal space. You can have this with inflammation if they have a migrating foreign body, if the animal happens to be from California and has a migrating plant on. You can see this if they've been hit by a car and they've actually avulsed their ureter and they have urine leaking into this space. And it can be seen with neoplasia. The other thing you have to remember to do is to look for sublumbar lymphadenopathy. So just to remind you, the retroperitoneal space is everything under the sublumbar, under the lumbar spine. And you can see that this animal has increased opacity in his sublumbar musculature, and an increased opacity in his sublumbar region, especially caudally. And these are actually very enlarged lymph nodes in a dog with lymphoma. We're going to move on, now that we've talked about the general abnormalities, to talk about the specific organs. Liver is something that we can evaluate reasonably well. We can look at its margins to see if it has nodular margins, if it looks like it has a mass. We can also look at its size. Liver size, radiographically, normal is defined by the stomach being parallel to the ribs, as you see in this case is not occurring. This is actually, this line represents the stomach axis and is displaced cranially, which suggests that this dog has a very small liver. Causes of very small liver include portosystemic shunt in little dogs, or long-standing chronic active hepatitis where they actually have cirrhosis and fibrotic changes. You can also have changes in the opacity of the liver. It's a homogeneous soft tissue opacity typically, but if you actually have air in the biliary system or air in the gallbladder, that's something that gives you an idea that you really need to actively pursue a infectious emphysematous disease in the liver that is going to need immediate attention. On the other hand, the liver, if it gets too big, is going to caudally displace the gastric axis. Focally, as in the top one, you can see that there's actually cranial or caudal and dorsal displacement of the stomach, indicated by the curved line. And this is most commonly going to see with a focal mass, either an abscess, a tumor, etc. It's important to know the common tumors that occur in the liver, a lot of which are benign, so that's something you need to think about. If you have a diffuse increase in size as we see in the bottom, what you're going to see radiographically is caudal displacement of the gastric axis, meaning it's as the red line as you see in this example. The other thing you're going to identify is that the caudal ventral margin of the liver is going to extend well beyond the edge of the ribs. There's a whole list of things that can be deposited within the liver parenchyma and cause a generalized enlargement. In the dogs, the most common one is going to be glycogen deposition because they're actually a dog with Cushing's disease. You can also get hepatic enlargement if you have venous congestion because you have primary cardiac disease. Spleen, that is an organ that enlargement, if it's not focal, is very subjective. If you have generalized enlargement, the most common cause is that the animal has been sedated with either a barbiturate or a acepromazine derivative. You also can get enlarged spleens in athletic animals, animals that have regenerative nodules because they have immune-mediated hemolytic anemia. But you can also see big spleens in dogs that have lymphoma or cats that have lymphoma and mast cell tumors. If they have focal splenomegaly, you have to remember not to immediately give them hemangiosarcoma. They do not have to have hemangiosarcoma. Every dog with a big splenic tumor. They could, in fact, have a hematoma. They could, in fact, have regenerative nodules. Or they could have hemangiosarcoma or another neoplasia. If they have a decreased serosal detail, suggesting they have some fluid, and you tap it in its blood, it's going to be more likely a hemangiosarcoma, but you cannot tell from looking at radiographs whether it's a benign or a malignant process. Pancreas is typically going to be invisible in the abdomen. If you think about it, it's only about 1 centimeter. It is located caudal to the greater curvature of the stomach and along the medial margin of the duodenum. If you have pancreatitis or pancreatic neoplasia, because they do look very similar, you will have a mass effect in the right cranial quadrant of the abdomen on a VD projection. You can have what's called ground glass appearance in that area, which is a loss of the serosal detail secondary to the inflammation surrounding the inflamed pancreas. And then one of the more specific things of indicating pancreatic body or left limb disease is that you have a separation of the stomach and the transverse colon, where the enlarged pancreas actually causes the transverse colon, which normally sits right adjacent to the stomach, to be displaced caudally. If we talk about the stomach, the air fluid distribution is a very important aspect for you to consider. Typical right lateral projections, the pylorus will be fluid-filled. It can have the deceptive appearance of a mass or a ball because it can be quite round. And I just go through a list of abnormalities of what you might see with various different diseases. What's important to remember in the stomach is that wall thickening is not something that can be identified just on plain films, but you do need to consider doing a contrast study or ultrasounding them. And then the reason is that if you have fluid or food that's adhered to the mucosal folds, it's going to look just the same as a thickened stomach wall. Just to remind you, GDV, or gastric dilatation and volvulus, in large breed dogs, something that very well may appear on the national board exam. This is a right lateral projection of the cranial abdomen. The pylorus is displaced cranially and dorsally, and there's a thin pillar of soft tissue that compartmentalizes this vast distended stomach into two areas. Small intestine. We're going to go back to the Rankin signs, which I started with earlier. You want to look at the size of the small intestine. Again, you can't look at wall thickness because if there's fluid or food adhered to the wall, it's going to make it look artificially thickened. You want to look at the position of the small intestine. Is it being displaced by some mass in the abdomen? You want to look at the shape or the contour. Is it stacked? Does it have little comma-shaped gas bubbles and plication suggesting it's a linear foreign body? You want to look at its radial opacity. It should be a nice soft tissue opacity, but sometimes you can identify a foreign body such as a rock or a bone or a pecan, as we just saw the other day. And then if you really can't entirely figure out what's going on, an upper gastrointestinal study, or UGI, is what you want to do next. And the primary things you're going to evaluate in that is the mucosal margin, whether or not there's an obstruction or not, and whether or not you have normal motility. And just as an aside, I just want to tell you what the major mistake that people make in performing an upper GI is that they don't give enough barium to the animal. And what happens then is it doesn't fully distend the stomach, and you don't get normal small intestinal emptying and stomach emptying. And so you get an abnormal study, and you're just not entirely sure what's going on. So always remember to look up the barium dose and tube them and give them their full dose. So small intestine, what we usually care about is whether they're obstructed or not obstructed. So in the cat, there is an ultimate size limit, which is 12 millimeters. And in the dog, a normal small intestinal loop, which can be fluid-filled or air-filled, is approximately the height of a lumbar vertebral body, or twice to 3 times the width of a rib. This is a dog with small intestinal dilation. This is primarily gaseous dilation. And what we see in this case is that the dilated small intestinal loops are greater than 1.6 times the height of the body of the 5th lumbar vertebrae. And there's a paper in the literature that correlates that degree of distension as being suggestive that that animal truly has an obstructive disease and not just gastroenteritis or parvo or something else like that. Large intestine, same things are going to apply as to small intestine. It has a very variable position, just like small intestine does. There are very poor definitions of what's normal and abnormal for size, mostly because it's variable on what diet they eat. Megacolon is really a clinical diagnosis unless they have an obvious restriction in their pelvis. And then one of the things that you may be questioned about on the exam is intussusception. So I've listed the 3 common types of intussusceptions. And you can see in this animal that there actually isn't soft tissue opacity, tubular, within the colon. And you can see just ventral to the 1st lumbar vertebrae, a rounded margin outlined by air that actually is the distal portion of this intussusception. Intussusception may be something that shows up on the ultrasound section, and because it has a characteristic appearance of bullseye. So looking at the history and looking at the ultrasound, you may be able to determine that that's what's going on. I'm going to move on to talk about kidneys. The normal length of kidneys in the cat and dog are listed here, and that's going to be compared to the length of L2 on the ventral dorsal projection, not the lateral, ventral dorsal. So how do you get small kidneys? If you have chronic renal disease, or if you have some sort of renal hypoplasia or dysplasia. Dysplasias and hypoplasias have been reported in all species and many breeds of cats and dogs. It's going to occur in the young animal, and typically they're going to have small, misshapen, sometimes hard to find kidneys. Enlarged kidneys, or renomegaly, there's a number of causes. The neoplasias that most commonly cause enlarged kidneys, this is a BD. You can see these kidneys are much, much larger than 3 times the length of L2. Lymphoma and renal carcinoma. You could have hydronephrosis, can cause very enlarged kidneys where the cortex becomes thinned and atrophied because of the pressure of the fluid in the pelvis. In the acute toxicities like ethylene glycol and the acute infections such as pyelonephritis, you may see mild enlargement, but generally not huge enlargement of the kidneys. Perinephric pseudocysts and polycystic kidney disease are more rare causes of enlarged kidneys, except in Persians where polycystic kidney disease is a known congenital abnormality. The last 2 are really places that ultrasound is going to be helpful. This is a lateral projection of a cat abdomen. You can see one normal kidney sitting up underneath the body of L3, and then the very abnormal kidney sitting ventral to it. You can tell that this kidney is arising from the retroperitoneal space, or that this mass is arising from the retroperitoneal space, because it's ventrally displacing these small intestines. If it was on the VD, you could also see this as well, that they were being spread to either side. The next step in this case would be to ultrasound this animal to help you determine what specific abnormality is going on. Bladder calculi, getting to the end of this. I'm only going to touch upon them on the bladder because most of the bladder abnormalities need to be diagnosed with double contrast studies or with ultrasound. But you do need to remember which stones you can see on plain films and which stones you can't. So most common cystic calculi or most common bladder stone is the struvite or triple phosphate. It is radio-opaque. Calcium oxalate is the next most common. It is also radio-opaque. Silica, which are very rare, you can see radiographically. Cysteine, which are very uncommon, you cannot see on plain films. And urate, which are common in the Dalmatian and in the dogs with portosystemic shunts, you also cannot see on plain films. To review the cystographic studies, just quick, but you can see all of them on ultrasound. Okay, so if they give you a question that says you can't see them on radiographs, but you can see them on ultrasound, you need to say that it's either of the two that are non-radio opaque. So which cystographic studies are useful for which abnormalities? Positive contrast, which means that you're injecting an iogenated contrast material, not barium, into the bladder, is useful in those dogs or cats that you suspect have a traumatic rupture of their bladder. Negative contrast is going to be good for outlining the mucosal margin, tumors, etc. If you're going to use negative contrast, you might as well inject a little bit of, negative contrast being air, you might as well inject a little bit of iogenated contrast in order to better outline the abnormalities. So double contrast cystograms are very useful for filling defects, mucosal abnormalities, urinary bladder infections, cystitis, identifying non-radio-opaque calculi, and blood clots. Uterus, this is another area where you can make fatal mistakes if you aren't careful. Enlargement of the uterus, which if you remember is going to lie between the urinary bladder and the colon on your lateral radiograph, and on the VD radiograph is going to curl up along the bilateral body walls. And enlargement of the uterus means that that it is larger than the surrounding small and large intestine, or small intestine at least. But deciding whether or not an animal is pregnant, or whether it has an infection of its uterus or a pyometra, is entirely based on its clinical signs. So if you have a dog that is totally happy, healthy, and you radiograph it and it has uteromegaly, then you need to, and she's not pregnant, she's not spayed, you need to suspect she's pregnant. Versus the dog that has increased urination, increased thirst, a fever, she's lethargic, that dog is more likely to have a pyometra. When can you first detect pregnancy? Radiographically, you're going to first see evidence of an enlarged uterus between 25 and 30 days in the dog and the cat. There is a phase in the dog and the cat where they will appear as little spherical structures, but I wouldn't count on being able to identify that portion of the pregnancy. And then for the most definitive detection of pregnancy, you're going to want to look for the point at which there actually is fetal mineralization. And the most reliable time to start doing that is at 45 days. Radiographs are also the best way to count feti. That's not a diagnosis that can be made on ultrasound, or not a number that can be definitively called on ultrasound, so you really need to radiograph animals in order to count how many babies they're going to have. Finally, we're going to end with prostate. And this is another thing where it really depends on whether the animal's clinical signs and whether or not they're intact or neuter. So the first three things, the BPH, paraprostatic cyst, and the prostatitis, are most commonly going to occur in your intact male dog. These are abnormalities. The benign prostatic hyperplasia is just enlargement secondary to hormonal stimulation. It's going to be nice and symmetric radiographically. It's going to be hyperechoic on ultrasound. And it's not going to have any evidence that it's destroying the capsule or it's lobulated in shape or anything like that. Versus a paraprostatic cyst, where you'll see both the prostate and then another large lobulation off of it. Or prostatitis, where you can have a very enlarged, very irregular, no longer symmetric prostate. And then finally, prostatic carcinoma, which is all of the abnormalities I described up above. It also can have mineralization within it. And the big time you're going to really suspect prostatic carcinoma versus one of the others is in the dogs that have been neutered since they were puppies and now have a big prostate. Those are the dogs that you really need to worry that have prostatic carcinoma, and that's a bad thing because it's a bad disease. So my conclusions for this, I know we flew through all of this, but when you go to take the exam, make sure that you read the question carefully so that you can extract all the clinical information that has been provided for you. Because just like the radiographs on this lecture, sometimes they're going to be hard to see. So you really need to make sure that you have all the information from the question to help you interpret the films. You then need to systematically read the films so that you can be sure that you've looked at everything. And then also you need to remember that these abnormalities are going to be fairly obvious. They're not going to be subtle, because it's going to be very difficult on a computer screen with a small image to have you pick out a subtle abnormality. So I'm looking forward to your questions at our live question and answer review. And thank you for your time, and I hope I've been informative.